Without further ado, kepada Dr. Ivan kami persilakan untuk memimpin sesi panel discussion.
Dr. Ivan menjabat sebagai Komisaris Utama PT Bunda Medik Tbk, Bunda Hospital Group, dan CEO di Morula IVF Indonesia. Dr. Ivan juga menjabat sebagai perwakilan negara Aspire dan salah satu anggota pendiri Asian Society of Gynecology Robotic Surgeons dan saat ini menjabat sebagai ketua di Indonesian Reproductive Science Institute or IRSI. Dr. Ivan, over to you.
Okay. Thank you very much for the kind introduction. This will be our last session for the day. Thank you again for inviting me to moderate this session, and hopefully we have a very productive 1 hour. So I'm not going to reintroduce Professor Fatemi, but I would like to invite several panelists to attend our session today. So the first okay, let me just check. Okay, so Professor Nusrat will be replaced by Dr. Binarwan. Is that right? Yes. Okay, Dr. Binarwan, of course, so we don't have to introduce that. Binarwan, very famous doctor from Medan. And the next one, Dr. Ari Polim, who is one of the leaders in IVF for Morula, Jakarta. And Dr. Chakra, who is a very famous doctor from Palembang, of course. When we talk about Dr. Tommy being a celeb, I think every doctors here are celeb doctors and quite famous for their social medias. And last one, Dr. Bilioni, very famous doctor from Tangerang. So, yes. Udah semua ya? So we have several interesting questions that we will address this afternoon. And of course, the topic of how we can establish what we call a so-called precision ART, which I think this is a lot of, innovation is trying to establish, particularly the areas of AIs and the clinical aspect, the laboratory aspect. And I'm glad to have an earlier discussion with Professor Fatemi about where we are at the moment and really learn so much from his lecture today. So he did briefly mention about the OHSS, which again is something that we were so very, I think, put this at the very top of our mind, if you like, for the events of morbidity or mortality for IVF treatment. Seems like an extinct conditions already now. So it seems. Six years. Whether that practice of freeze-all might have contributed, or do you think there's another sort of element to it, a modification of your way of stimulation, or the way that you manage post trigger that contributed to the existence of the HSS that you don't see anymore now?
Thank you for this very important question. I don't think that freeze-all is the only reason. Of course, it's a major contributor because you eliminate late OHSS. That's a major contributor, but that's not everything. We have published the first case of OHSS after agonist. It was an FNS paper, I think 2012, 2013, we published that. So even with an agonist triggering, you can have OHSS because you have no neutral license. So the fact that we don't see OHSS is simply because we are individualizing the treatment according to the patient's requirement. We adjust the dose, and by the way, we barely use agonist triggering only. We use it only if the patients are scary exploding with 50, 60 follicles. Most of the cases we use dual trigger because we are running another study where we are comparing agonists versus dual trigger, egg quality, and so on. But to come back to your question, I think the elimination of OHSS is mostly because of individualization of the treatment of the follicular phase, individualization of the pharmacosite maturation, And obviously also freeze-all is contributing to that. So it's not only the freeze-all, it's multiple factors contributing.
Interesting aspect you pointed out about the variations of triggering, sort of modalities that we have. If we consider that, I mean, Kobelanakis, almost a decade ago, proposed the use of that agonist, and I see that there are several changes, things that are happening. But why don't we see that? Sorry to say that, not to replace the recombinant HCG that Merck obviously has, and replaced it all agonists. Why do you think that?
The problem is it's very difficult to show it because of heterogeneity of the patients. But again, let's go back to nature. Let's go back to nature. What happens with an ovulation? With an ovulation, LH goes up. It goes up, and then you reach a plateau for 2 days. And after 72 hours, it goes gradually down. So basically, it takes you 3 days to go down. When you give an agonist triggering, what happens? You go up 4 hours, and within 12 to 16 hours, you go down. So in fact, your LH rise, it's like a OS. It goes rapidly and it goes down rapidly. Does it create final egg maturation? Yes, it does. Would it be the same like nature would have done? Most probably not. So our impression is that the egg quality is not always the best as it can be. Now, we don't see that because most of these patients have a lot of eggs. These are hyper responders with a lot of eggs. So you still have a lot of eggs and you're happy because you end up with your blastocyst. But could it be that you would have created better embryo division pattern, better fertilization rate, better blastocyst formation, and so on? We looked to our database and we had extensive discussions internally. We did not find a significant difference. The problem is the heterogeneity of those patients, because those patients we give the agonist only are really explosive patients. And the other patients, they have less eggs. So you are comparing 2 different groups of patients. But most probably, if it would be the same group of patients, well, of course, then you could not eliminate the risk of OHSS because these are explosive patients. So if you ask me, if you ask my friend Juan Garcia Velasco, they are happy with it because they use all the donors with agonists. They are very happy. Many publications didn't see any issue. But my impression is that agonist only does not give you the best quality eggs. Very often, you see, we have on weekly basis discussions with our embryologists. And when they have bad egg quality with a lot of eggs, the first thing they say, they call me, was it an agonist triggering? Because they know that is creating lower egg quality. So most probably because they have a lot of eggs, it's not seen. But some patients, you don't see that. But with some patients, you might have lower egg quality.
Proportion.
It's difficult to see. I think most probably 70–80% of the patients will give you perfect results without any problem. But it's this 20–30% which you might improve by giving the ACG. Now, which patients might that be? That's the question mark. Now, Biljana Popovic published a paper that, for example, if on day 2 or 3 of the cycle, your LH is less than 1 or 1.5, you should not utilize the agonist because you fail to have it. But that's a tool not to use the agonist only. But most probably for the quality, we need to look to other variables, which are currently unknown to us.
Okay, so let's see what the panelists think. Dr. Billy, what's your practice?
I normally do dual trigger. It's actually combinations between HCG and agonist trigger. And therefore, for that case, we normally do not do fresh transfer, as we have addressed the reason why.
And what's the purpose of that?
We observe that the quality of the oocyte actually increase, maturations of the oocyte actually increase. If we compare just HCG trigger as compared to combinations of HCG and agonist. However, we do agonist triggering to avoid hyperstimulation syndrome for certain cases where the estradiol level, let's say, reach above 4,000 picograms on the day of the trigger. Yes, we only do agonist trigger and freeze all definitely.
Yeah, there's a meta-analysis done by the Chinese group about a year ago. It was published about the comparison between the dual trigger routinely to the conventional recombinant. It seems to be, again, there's an argument to that, how that actually would change. Number one, the fact that we freeze them all anyway, and seems to, but what we're worried about is the second wave rather than the first one. But again, whether that actually truly will give the benefit of the quality of the oocyte yet to be seen, because most of the end parameter has not really been seen quite clearly when we're trying to address clinical pregnancy rate, right? So that'd be quite interesting aspect. Dr. Binarwan, do you have anything to say?
Yes, I cannot agree more with what Fatemi said about triggering with GnRH alone. I have numbers of cases with a very high responder, and I just give only the GnRH alone. But it seems to be quite a lot of bad quality is coming up. So now, although it's a very high responder, I still use some of the SCG like 3,000 or 4,500, but I don't see any risk of OSS high up with that dual triggers.
So percentage of agonists?
I think now I'm abandoned it.
Abandoning. You? How many percent of your patients you had to have agonist trigger?
We have more than 25, 20x that I just agonist.
That's 5%?
Yes, I think was that 5%.
Stop. Okay. Dr. Ari?
Yeah, in my clinical practice, how can we use the agonist trigger? Not all for the patient. That if we want to transfer the patient with the agonist trigger, I think we need about the addition of the estradiol. Yeah, maybe the dose of the estradiol and the low dose of the HCG, because in the Humeden protocol that use that patient with a high estradiol level above the 3,500, and I think that there is maybe we can transfer no OSS risk to the patient. Yeah, why not? We can transfer that by in the agonist trigger. We need to absolutely to addition of the estradiol and low dose of the FCG, maybe 1,500 for the support of the luteal support that. I think that.
Okay. So seems like everyone agrees that we're using less and less routinely for agonist trigger, but quite interesting we use routinely for all patients. That's something that, again, do we use any agonist prophylaxis for patients who are at risk for HSS, if there is any risk of HSS?
Antagonist prophylaxis, yes, we do. Yeah,
All?
For those who are at risk, we observe after giving antagonists on the day of OPU, and we follow 5 days afterwards. We've been doing that for the last 1 year, and there hasn't been any hyperstimulation cases reported with that kind of protocol. So I think we are very happy with the use of antagonists after often pickup.
Do you ever use that in your practice, to use agonist prophylaxis?
So when patients have too many follicles, the problem is during the weekends on Sundays, we don't work. So we don't want the patients to go to any other clinic where they don't know what they are doing. And the patients, they would lose both the ovaries simply because they have some pain or discomfort. It's not hyperstimulation, it's discomfort. So we don't want them to feel anything. So we have something that we call it OHSS cocktail. Not a mocktail, but a cocktail. We give them antagonists. If they have more than 30 follicles that we retrieve, we give them antagonists. We give them letrozole 5 milligram, and we give them Dostinex for 5 days. And that suppresses the estradiol level, that suppresses everything. So basically, even if they have 40, 50 follicles, when you retrieve, they will not go anywhere, even on a Sunday, because they will not feel anything.
Okay. Okay. So it seems that there is a practical value, and hopefully we don't get to see those patients anymore now these days, because we control the patients. We sort of modify the personalized approach, right? So this is an angle that is quite interesting because obviously we can't forget probably at the moment the fact that OHSS is not a big concern to us anymore. The next question is how we can improve our outcome. Now, many of us actually are facing the same problem with poor prognosis patients. And of course, with this poor prognosis patient, we're left with many things that we consider to be beneficial, but many of them are very controversial. Let me just start with PRP. Do you use PRP at all?
So we are running a study again with PRP, and we don't see any difference. Now, if you take a look at various publications over the past 2 to 3 years, it's like metformin and PCO. One study is telling you it's beneficial, the other is telling you it's not beneficial. I think it's again based on the heterogeneity of the group. We are doing a study since 2 years now where we inject one ovary with PRP, the other ovary with saline, and we don't see any difference.
So do you think that the PRP itself physiologically may have any benefit?
No. I think if there would be any impact, it's the same what Kawamura did with his chopping of the ovary and putting it back. I think it's a kind of aseptic inflammation of the ovary that we create. So most probably if you go inside the ovary and you just go in and out the ovary, you create damage, right? When you create damage, your body tries to repair it. How does your body repair it? Through neovascularization, more blood supply. It's a healing process. I think this neovascularization, this healing process might temporarily improve the follicular recruitment because you simply have more blood going to that area. And I think that's the concept behind all the studies which are looking to these poor responders, simply damage.
So the question that I did ask you earlier before, that you said that all of the eggs are basically normal to begin with. It's our influence that actually creates the problem. Then the question is, if we are expecting improvement out of this poor prognosis patient, would it be sensible to actually refine their sort of recruitment process in the first 2 months with so-called adjuvant like PRPs?
This is the study I told you I want to do with the animals, and I can elaborate more in a smaller group. But yes, I think there is a possibility even to get healthy eggs with elderly women. Because I think these eggs, principally, they are not unhealthy.
Yeah.
Because they're dormant. They are there, they are dormant. The chromosomes are there, they are not modified. I think the problem occurs the moment we start recruiting them and stimulating them, and whatever happens after that. To give you an example, I just mentioned previously the fact that we have had responders where you would expect a lot of genetically abnormal embryos. The only live birth that we had was at 11, 12 millimeter size follicles. So I think it's a complex interaction between your endocrine profile, your final oocyte maturation, the dose of maturation, mode of maturation, stimulation, E2 progesterone per follicle. There are so many variables which play a role that at the end, the question comes, okay, where does this abnormality come? Most probably recruitment and final maturation. I think this is where the mistake is happening. So if you could go one step back and try to modify the environment where these eggs are being recruited, most probably you could avoid this aneuploidy even at elder age.
The same philosophy applies, then stem cell would not be in place for this approach, would it not?
Absolutely. Absolutely.
Anyone would have different thoughts?
Well, we've just started using PRP actually, and we observed that the Poseidon group that gives highest benefit from PRP is actually the group 3, where they are actually young, but they have diminished ovarian reserve with low AMH, low antral follicle count. But surprisingly, Prof, we did have good results and even pregnancy coming out from these cases. That is obviously so we prime the patients with PRP before we stimulate the patients. But again, we've just started, so we still have to collect more data before we can come to any conclusions.
Do you want to share us how you approach your PRP?
Well, we honestly told the patients that it's still basically it's a very preliminary study, but we do have some quite successful cases, and if they would like to try, and most of the, because pretty much they are desperate patients, right? Because they don't really have that many options. Instead of going 2 cycles with let's say double stimulations or consecutive cycles, PRP might be a cheaper way of approaching, I guess. Yes.
Anyone else might have thoughts on PRP?
Yeah, I think in theory, PRP is contain many the growth factor that can increase about the tissue regeneration, can ovarian wound healing, and increase the angiogenesis and angiogenesis. And in theory, also that the PRP can increase about the estradiol NABH level and parallel to decrease of the FSH and LH. But until now, the many conflicting data about the result of the pregnancy rate of the PRP. Some results say that the pregnancy rate is 28%, the live birth is 28%, but still limited data to do. In my clinical practice, I will do the PRP in the patient with maybe any POI or POF that, but yeah, we collect the data until now is maybe it's still not still ongoing. Yeah, how about the result of the PRP and maybe for the future is, I think, is promising.
Maybe just quick thoughts from Dr. Binarwan.
I have tried this PRP for quite a couple of years, but the result seems to be not satisfactory. Yeah? Sometimes it's good, sometimes not. So I come with the conclusion that the PRP is actually not beneficial, especially for the genuine poor responder. But I don't know there is a hypo responder cases. This case I hasn't been tried it yet.
Right.
But the genuine, definitely I don't see any benefit from this, so I stopped to do it.
It's part of the closure.
Yes.
Doctor?
Yeah. It's quite interesting about PRP. But yeah, I think it's the same with the Dr. Binwan, that the result is very I think. Some patients have benefits, some not, especially with patient with old patient and very low ovarian reserve. I think the result is not so promising. But in my experience, the benefit of PRP could be better in patients still young and the ovarian reserve is still not really bad, maybe more than 0.5, maybe could be some
Okay.
benefit with PRP.
So if you don't have PRPs, what is on top of the list that you consider as an adjuvant treatment for these patients in your normal practice?
You know, if you look back to all the add-on or any additional treatment modality which have been proposed for the poor responders, what have you? DHEA, transdermal testosterone, growth hormone, PRP. Each one of them, they have been contradictory. Even the transdermal testosterone, Nikos presented the data at ESHRE last year, where it demonstrated multicentric trial, even the transdermal testosterone did not add any benefit. DHEA, what Norbert Gleichert was promoting, other studies failed to demonstrate any benefit. Growth hormone, Golobianaki is the same. PRP is in a small group, we all are contradicting each other. Why is that? It's simply because of the heterogeneity of the population we are talking about. See, poor responder is not equal poor responder. You need to understand, okay, what is the poor responder? You could have 2-3 follicles with an FSH of 10. You could have 2-3 follicles with an FSH of 5. You see, that's already one variation. Now, the other thing is the intercycle variation you have. You see, the same poor responder who has 2 follicles today, maybe in 3 months, she has 5 follicles. Maybe she has 4 follicles. And all these variations have not been put into cohesion. You see, even studies, they don't put the intercycle variation into cohesion. But if you ask me, what do you do differently? The problem is the patients come to you, and if you don't give them, in Arabic, a pill is a hubub. They all want to take a hubub. If you don't give a hubub, they're not happy. You have to give them a hubub, right? If you no hubub, no good doctor. So they all expect you to give them some kind of hubub. And if the hubub is an injection, it's even better because injection is even more good. They're happy, right? You are a better doctor. So they expect you to give them something. Now, I tell them the truth. And if they say, I want to take something, I give them testosterone, I give them DHEA. Do I believe in it? No, I don't believe in it. But I think what is important is the timing of final oocyte maturation. I think that's important. And that is what we just published, that we have a computer program. It's looking to the cycle length. It's looking to the basal FSH, and it calculates and what would be a good time to trigger that particular patient. So what we do differently is the timing of final oocyte maturation. And with these extreme poor responders, as I mentioned previously, as small as 12, 13 millimeters.
Interesting you say about intercycle variations. We did a retrospective analysis for our current group with mini stimulation serially over the period of 2 to 3 cycles to obtain 2 to 3 embryos, and the finding was similar outcomes, about 17% pregnancy rate. But the cost is actually a lot more with a repeated cycle as we expected. But do you think mini stimulation has any roles in treating these poor prognosis patients?
I think if financial issue is an issue, what one could do, and if the patient understands it, you could see the patient over 2 to 3 months, and then see when they have the best endocrine profile and the best antral follicle count. Because this intercycle variation will be there. And then you can capture the time where you say, okay, now she's having 4 or 5 follicles. She usually has 1 or 2 follicles. And then that is the time where I would say, okay, go with the stimulation rather than stimulating. Now, mild stimulation, I don't know where to begin with. Mild stimulation for a poor responder, mild stimulation for a normal, mild stimulation for a high responder. So let's focus on the poor responders.
Yeah.
Now, imagine the patient is having 1 or 2 follicles. And I stimulate, I would have 1 egg. Why should I stimulate her? So we go with the concept of managed natural cycle. So they have already elevated FSH. Because they have elevated FSH, even if they have 2 follicles, both follicles will grow because the FSH is elevated.
Yeah.
So there is no need to stimulate them. We just add maybe 1 or 2 days, then we trigger. But if they have, let's say, 4 or 5 follicles, no, then we don't go with the mild stimulation because we want to have a multifollicular recruitment. But mostly what you see with these patients is an asynchrony. The follicles are not fully synchronized. So with these patients, we try to do a luteal stimulation. We let them ovulate. After ovulation, we stimulate them because we have a more synchronized follicular cohort.
Okay. So I don't have any comments about mini stimulations at all.
For mini stimulation, yeah, I think in one study said that mini stimulation, mild stimulation compared with the conventional IVF, I think the effect is not significant different, but the cost effectiveness, mini stimulation is more effective than the conventional IVF in the from the buyer perspective. But in my opinion, if the patient with a poor ovarian reserve, yeah, we need more oocyte. Yeah, why mild stimulation can we do for embryo collection? Yeah, but for the patient with the normal reserve or high reserve, I think it's not the place for the mild stimulation. Yeah, because we need more oocyte, more embryo, more blastocyst embryo, and more euploid embryo to increase the pregnancy rate.
Okay. Okay. So we'll go to the. Actually, we've run out of time already. Have we? 7 minutes over. 30. Oh, 20. 7 minutes left. Okay, let's just carry on with the another topic. Let's talk about endometrial receptivity. I already mentioned you don't like endometrial receptivity test very bluntly. So tell me your thoughts about how we can adjust this, justify our timing of transfer. Would it make any difference if we could pursue further of this, sort of a so-called window of implantation?
That's a very difficult question to answer. Most probably, in the window of implantation, does not differ significantly among women. It will be based on 120, 140 hours of progesterone exposure. But I think what will differ among women is the progesterone levels. You see, you need a certain level of progesterone to create a secretory transformation, and that can happen with very low levels of progesterone. But the pregnancy is like a transplant. You see, you get half of genetic material of someone who is usually not related to you, right? So the body will reject it. So there is also a lot of immune system activation. Progesterone is also an immunomodulator, right? So I think progesterone has three major tasks to do. One is the so-called secretory transformation and preparation for implantation. Two, reduce the contractibility of the myometrium. And three, which is very important, working on the immune system in the systemic circulation. Now, the dose of progesterone, which is creating the secretory transformation, that is based on the number of receptors which are there. If the patient has any fibroid, adenomyosis, obesity, endometriosis, high levels of estradiol, all these entities create more progesterone receptor resistance. So when we say optimal receptivity, you need to cover the progesterone receptors. Forget the window of implantation, the endometrium will not be receptive. So most probably the timing is not the major issue. So ERA was looking to one point on time, but I think time is important to be respected, but the amount of progesterone needs to be individualized, which is linked to the luteal phase. So if you ask me, how do you individualize the receptivity? I would say most probably it is linked to luteal phase support and individualized luteal phase support based on the demographics of the patient.
So again, there's a genetic sort of evaluation eventually of the endometrium, which again, this is something that we still very much in doubt of whether every patient would be screened for. And I suppose all of us do not do ERA on every single patient here, but any of us routinely offer ERA in difficult or challenging patients. Dr. Bin.
So because of the cost-wise, yeah, so it's the every time is my point of view. So the ERA is also expensive, and somehow I believe that if you do the individualized, personalized luteal phase support, I think it's better than to do ERA test. That is my point of view.
It's still controversial about the ERA. Even the history not support the ERA for to support for recurrent implantation failure. But and also in my experience before that, I never found that patient with the ART cycle that have different windows of implantation. So I stopped using the ERA.
Dr. Bining, Dr. Ari?
Yeah, I think in meta-analysis said that the ERA test, the prevalence of the endometrial receptivity, if you test in the endometrium, there is any displace of the window of implantation is, I think, 34%. But if we transfer patient with a non-receptivity and we do the ERA test, I think it's not significant different the pregnancy rate in compare with the patient with the receptivity endometrium with the usual endometrial transfer. And about the data say that I think, yeah, ERA test is not recommended to use routine use usual in the patient with the RIF. I think that, yeah, but in X-ray one recommended is the same. For the RIF, I think is the ERA is not recommended.
Maybe to add, there was a publication, I think last year in FNS, those patients with recurrent implantation failure who did ERA, They had significantly lower pregnancy rate than those patients who did not do ERA. This is one thing. The second thing is, based on that, there was a commentary in FNS, ERA, the end of an era.
The end of era.
That's why genomics is not there anymore for you then. Thank God they're not sponsoring this event. So, okay. Billy, any thoughts?
Yeah, I guess we were pretty selective in cases where we asked the patients to do endometrial receptivity tests. Maybe for those cases that we've tried everything. We've given sildenafil, for example. We've given blood thinning agents. We've tried peppering up. We try fixed dose. We try low dose recombinant FSH. Nothing works. The endometrial lining's pretty much only one line. And in that case, what do you think, Prof? Can we still try ERA maybe?
I told you, I mean, I don't believe in ERA, and I don't think ERA would change anything. When you have an abnormal endometrium, I mean, thickness, we have discussed previously, I don't think thickness is important, but the shape is very important. So if the shape of the endometrium is irregular, then obviously you do a hysteroscopy to see if there is anything, if you can create kind of aseptic inflammation in order to enhance the vascularization to see whether that's going to benefit. So these things that we have looked into the past, you see, the thickness, ERA, and so on, I think we need to refresh our minds and look into various options. And most probably these patients, if you create an aseptic inflammation in the endometrium, and I'm not talking about the scratching, I'm not talking about the scratching, I'm talking about the global aseptic inflammation of the endometrium. That might help in order to improve the receptivity of the uterus and possibly the vascularization, because every healing process goes through vascularization. The same is with the ovary, the same is with the endometrium.
But do you think It's okay. Do you think there is a value though, in any way that we can correlate any clinical deviations or anticipate to be optimal, i.e., you said the thickness maybe is never been optimal. Do you think a value of some evaluation of the period, the window implantation may be relevant to us at some point?
You see, as long as you respect the hours of progesterone exposure, the dose of progesterone, and you synchronize the embryo division pattern with the hours of progesterone exposure, I think you are doing good. You see, based on a paper we published with Baris Atta recently, recurrent implantation failure is less than 2%, less than 2%. So what are we talking about? We are talking about less than 2%, and this less than 2%, it could be anything. It could be immunological cases, it could be a genetic failure that we didn't find, it could not be a chromosomal abnormality, but a genetic abnormality that we didn't find. So there are so many variations. Personally, I think most of the patients will get pregnant if you respect the hours of progesterone exposure and the correct genetic testing. And that's difficult. To do a correct genetic testing is very difficult.
And you mentioned about the screening, particularly the genetic screening for recurrent implantation failure. So what is on top of the list that you see in your clinical practice? Of course, demographically taken into account will be different to what we have here, but what do you think will be at the top of the list that we would consider the main cause of the fact, only 2%? Are we actually under-diagnosed or are we actually over-treating this recurrent implantation failure as such?
I believe sincerely in genetics. I believe that the genetics plays a major role, specifically chromosomes and the haploid status of an embryo. I believe it's very difficult to do the genetics correctly. Hence, many publications didn't show any benefit because it's not done correctly. You see many papers from China which come out, they don't do the technicalities correctly. That's a problem. On the other side, we were looking to something which is called optical genome mapping. I don't know if you heard about that. That's a very new technology where you can identify a lot of things that you would not see with fish, for example. You see, you mentioned there is this doctor from China, he does karyotyping for everyone and he finds it. I can tell you, if you would do this optical genome mapping for everyone, most probably you would see 10-15% that there is a problem which even the fish in the karyotype would not have identified. So most probably future of IVF will be on the genetic level. I think the future IVF would be on the level of, okay, is this really a healthy embryo? Is this chromosomally a healthy embryo? The problem is, where do you put the line? Okay, this is normal, this is abnormal, this is mosaic, this is not mosaic. If it's mosaic, should I transfer, not transfer? But everything comes into the chromosomes of, and it's not the sperm, it's the egg. The sperm, I don't want to say it's placebo. A sperm is there to create an embryo. I think most of it is in the egg. Like the Romans used to say, life comes from an egg.
And if when the embryo has already been considered euploid, and you find the patient failed to get pregnant, would you consider that a potential portion of that, this patient belongs to that RSA group?
No, because we published another paper with Ashna Bayram, I think in RDM Online 1.5 years ago. Let's say you say the embryo is normal. Okay, good. Now this embryo, which is normal, now we have to go to detail. Is it, according to Gardner, BL5AA on day 5? Is it on day 6, BL5AA? Because BL5AA is equal to BL5AA, but it's not. Day 5 versus day 6. Already here, the implantation and ongoing pregnancy rate differs by 10%. Okay, so perfect embryo quality, but day 5 versus day 6. Now let's go further. Let's say the ICM is B and the trophectoderm is C, day 5 or day 6. Or it is CC or CD, day 5 or day 6. So not only the genetic status of that embryo is important, but also the embryo quality is important. But now you are looking at the embryo quality at one point. This is also wrong. You also have to go back. How did that embryo get there? Because it was 2PN, maybe it had 8 cells on day 3, maybe it had 12 cells on day 3. Maybe it had fragmentation 2 or 3, maybe it was 8 cells, 0 fragmentation. So through AI, we need to understand now, not only looking to the embryo quality today, the whole thing. You need to look through the whole information that you have, combine that with the patient's demographics, basal FSH, basal endocrine profile, BMI, ethnicity, and what have you. And then we need to answer the question, okay, the patient didn't get pregnant. Why did she not get pregnant? Now, if you ask me, if you have a young woman, BL5AA on day 5, 80 on day 3, and you put it back in a natural cycle, and your endocrine profile was good, she did not get pregnant, and the transfer technique, and this is another thing, you know, if you have the doctors which are traumatic with the transfer, that plays, of course, also a role. If the transfer was done smoothly without any issues, and she did not get pregnant, then a question mark could come. Okay, maybe that patient has some underlying problem. And then I would start doing some immunological testing to see if there is any problem with the KIR, HLA of the husband, if they are possibly incompatible, but not before that. I need to exclude the embryo factor first.
Do you use morphokinetic incubator for yours?
Of course, of course. So we use, we keep dynamic images. We have an AI system. We look to the whole information prior to taking a decision which embryo to transfer.
In terms of cost management, Dr. Bina was very concerned about the cost. How would that affect to your practice, Doctor, with the recurrent spontaneous implantation?
So, if we have this recurrent implantation of failure with the embryo with proven like PGS, proven euploid, and day 5 embryos that we're putting on 2 times, then there's no implantations, then we will might do some of the tests like APS test, then the ANA test, although it's not proven, but I think it's to prove some of recurrent implantation values, which is only 2%, is very difficult. This is not very much data to prove whether it's proven or not. So it's might like parts of everybody have a different interventions. So we might do a lot of things that like to fit one or each other is with the different ways, like with the PRP before endometrium, before we are putting the embryos, like with some of even not proven like SCG, putting inside of the endometrium. Sometimes we do the injections of low molecular weight heparins, do some prednisolone. We might do a lot of things and combine together and see the things how it happens. So I think this is how we do when we find those patients with the gradation failure. But maybe I want to ask some things to Fatemi about the shorter periods of proliferative phase during the HRT cycles. Some of the papers said this no matter if even it's shorter, it's no problem. Like less than 7 days of giving the estradiol, then if already enough, then they just started the progesterone. What do you think about that?
So we had a publication when we were doing studies with Organon at that time when we were developing this long-acting FSH. So 33% of women were ready on day 7. So very short follicular phase, day 7, not before that, day 7. And we saw that those women have the best pregnancy results. So most probably, if you reach even in 7 or 8 days, the thickness that you are happy with, that should not be an issue. On the other side, prolongation is not good. You see, some studies have shown if your follicular phase gets too long, let's say 25, 26 days, that might be detrimental. I think somewhere between 7 and maybe, I don't know, 18, 19, 20 should be fine. But before that, or maybe more than that, most probably it might be detrimental.
Okay. So just the last point on this recurrent implantation failure. Any points or anyone to have any thoughts about probably of the intralipid use?
Yeah, we talk about the IVF is many intervention about that, but in the SRA, the new SRA guideline only with 3 recommendations that the first were auto harassment of the lifestyle factor, how to optimization the lifestyle, and the second how to assessment about the endometrium thickness. Yeah, maybe the endometrium is very important. Maybe you can use the estradiol to increase the thickness of the endometrium, or there is remain thin. Maybe hysteroscopy. I think Fatemi said that is we can rule out of the maybe Asherman syndrome or no that. And the last, maybe we assessment about the any APS or patient with the high risk patient of the APS syndrome that. And for PGTA, I think we need to genetic counseling. We need a genetic counseling if there is any result about the abnormality of the chromosome. I think that.
Okay. Well, let's carry on to the last point they want to discuss. We don't get to see many obese patients in the this community, but we do, but in a different form. But you share us your experience with high BMI patients and how do you treat them typically?
You know, if you go to these countries in the Persian Gulf region, you will see a lot of obesity because about 40 years ago, 50 years ago, oil was discovered. So they completely changed the lifestyle, completely. Everything went upside down. So suddenly a wealth came to the country. There was a lack of movement, so they don't walk a lot. And there was a high calorie intake. So the data which were published by the World Health Organization, I think last year, the UAE, Kuwait, and Saudi Arabia are the top leading countries in the world for obesity. So we have around 60% of women, being obese, meaning BMI of 30 or above 30. So we are dealing with really a major health issue. Of course, this is affecting also the receptivity of the uterus. It's affecting the quality of the eggs. Now, specifically, the implantation rate with these women seems to be less as compared to other women. So we started looking, why is that? So we wanted to know, why do we see such a high rate of miscarriage even after PGTA? Because you would say you do PGTA, you should have no miscarriage. But I can tell you, Dr. Francesco Reis, who is working with us, has a paper in press now. I think we have maybe 17, 18% miscarriage rate after PGTA with these obese patients. So we are breaking our heads. Why do we see such a high rate of miscarriage in these obese women? Anyone, any idea?
Increasing inflammation by the increase of the aromatase process in the
Right? They have breasts like women, right? Why? Because fatty tissue has a lot of aromatase activity. So it makes a lot of estrogen. A lot of estrogen, breasts like women. Good. Now, what happens if you are a woman and you are constantly exposed to high estradiol? You create progesterone receptor resistance. So most probably these women who are obese, they have the same pathophysiology like endometriosis or adenomyosis patients, because they also have aromatase activity. So our theory is that most probably these women, first of all, the absorption of progesterone is less good if you give it vaginally. So if you measure systemically, they don't reach high levels. Even if they would reach those high levels, it's not enough. So most probably they would require more than other women because they simply have progesterone receptor resistance. So currently, we send it to the ethical committee in our clinic to do a study with these women, that we randomize them to treat them with intramuscular progesterone compared to vaginal progesterone, measure the levels. I'm sure that the intramuscular will solve the issue immediately. And it makes sense. They have the same pathophysiology.
Quite interesting when you refer that to obese women. What we have here in our society is many of our, I wouldn't say just ladies, but also the males as well, we don't exercise. So what happens that actually we would expect to have higher fat distribution amongst our patients. So would that actually correlate something that our practice, that we do not offer patients lifestyle improvement prior or throughout the process of treatment to allow improvement to reduce the risk of miscarriage rate, do you think?
Absolutely. I mean, the blood supply, the blood which is going towards the uterus, I mean, all that is linked to the physical activity. So with the physical activity, first of all, they would lose weight, obviously, but secondly, you would improve the blood supply. And I think that makes a major change. Yeah, absolutely.
So example, as Professor Fatemi runs 1 hour per day, something that we need to reflect on ourselves, how many times we run on a daily basis. I suppose we need to readdress that to ourselves. Dr. Chakra, he's also a very good sportsman himself. So
It's quite interesting about its implementation in obese patient, because some studies looked at in obese patients the LH level is low, because the increase of the clearance of innovative LH and also the decrease the amplitude of the LH pulse, and also higher androgen can reduce the LH level and also the leptin resistance. So it could be rational if we maybe we can give LH supplementation with obese patients.
just before I go to the other panelists, do you routinely offer LH, and how do you sort of define your regimen for this, Professor Fatemi?
About the obese patients. So basically, we start measuring now the progesterone the day before transfer. And we start adding now intramuscular progesterone, but obviously we are doing a study in order to see whether that's going to change the problem. And then we have to distinguish between HRT cycle and natural cycle.
I mean, the recommended LH.
Recommended LH. Of course, we always measure, and if necessary, we add if it's required.
Okay. Do you alter the dose or increase the dose or?
Not really. I mean, the problem is it's very difficult to see which patient would benefit. Some patients, when you give FSH, you see the follicles are growing, but you see the E2 per follicle is low. And when the E2 per follicle is low, it means they would require to have some LH activity. Then we add LH in order to improve the steroidogenesis. So we don't look only to the LH level itself. We look to the follicular recruitment, the E2 per follicle, and in after 5-6 days, we see the E2 per follicle is low, then we add the LH in order to improve the steroidogenesis.
Okay. Maybe Dr. Billy, an experience with the LH for obese women?
I guess I will only add LH again, even if the patient is obese, if the LH actually fall outside the LH ceilings. Otherwise, I will not add the LH.
Based on the obesity alone?
Yes, based on the obesity alone, yes.
Would you, obviously it's not fair because you give patients double trigger anyway. So would you increase the dose for your trigger, do you think?
If I eventually give the LH, well, depending on how low the LH was during the checkup, normally we do the checkup during the before we give the antagonist. So if the LH is significantly drops or is somewhere between the low levels, and then we presume by giving antagonist the LH will definitely drop even more, then yeah, we will adjust based on the numbers. Yes.
Dotari, maybe?
Yeah, I think it's very patient with the obese or extremely obese that there is a theory and there is any leptin resistant can make and decrease about the LH amplitude of the pulse of the LH. Why the LH is very decreased? Why we need the more addition of the LH to increase the stimulation of the gonadotropin and the ART patient. But you said about the trigger, I think if the obese patient, some studies said that, maybe we need more trigger to increase of the oocyte maturation. We need maybe the dual trigger to increase the maturation of the oocyte. But I have maybe one question for Fatemi that in the obese patient, the PCOS and non-PCOS, is the same rule to need the addition of LH?
What we look at is not PCO, no PCO. We look at E2 per follicle. Because most probably the estradiol production per follicle is a reflection possibly of the egg quality. So once we see that E2 per follicle, of course, you could ask me how much is it? Again, this is something through AI. We are working on it to see what is a good level. But let's say if you have 15 follicles of 12, 13, 14 millimeters, and your E2 is 200 or 300, this is very low. You would expect with these 15 follicles to have an E2 of 800, 900. So most probably there are some patients who would have benefited from additional LH activity. And I don't think that measuring the systemic LH would answer this. It would not. Because most of these patients, when you see them back, you have given the antagonist. When you give your antagonist, what do? You suppress your LH. Bernadette Monarchs and Wet published this, I think, 1998, 1999. The moment you give your antagonist, your LH goes low. It's less than 1. So how on earth you want to measure your LH? Okay, this patient needs or this patient doesn't. And that's a mistake many doctors do in China. But you see, they measure the LH and they don't understand this antagonist suppressing your LH. So that's not important. Important is the granulosa cell activity, 2-cell to gonadotropin theory, your basic physiology, which is contributing to the estradiol production of that follicle. And most of these patients who are not producing enough estradiol, funnily, these are the patients who also have premature progesterone rise, because they cannot convert this cholesterol further to E2. So instead of producing E2, they produce progesterone. So it means you are pushing too much with FSH, and they cannot produce more because they don't have enough enzymatic activity to do so. So those patients would benefit from addition of LH or even ACG activity.
Dr. Binawan?
So I observe some of the patients sometimes with the obese patient and with the PCOS even, then we can see the level of FSH and LH they are some of the subtypes, they have LH lower than the FSH itself. And then I have seen this type of patients might be benefited with the LH supplementation. So if we see in the male infertility, they know the terminology of MOS, male obesity related hypogonadism. So they also implemented what is they call FOS, female obesity related hypogonadism. Is like they said is about the disturbances is amplitude of the LH itself. So even we compare the lean patients and the obese patient with the PCOS, the PCOS patient got lower LH level compared to the lean patient. So I have several patients which have failed in stimulation with the FSS only. So I just supplement that with the LH. It seems that I got a better quality of eggs.
It's interesting you said that you measure your LH prior to stimulation, then often we can see as a reverse kind of a high LH sort of appearance in PCOS patients, and justifying the LH can be quite challenging in such way when you want to consider supplementing patients with recombinant LH. But again, to people who do not use blood tests quite routinely to their patients, which again, this adding to cost for the patients, how are we justifying really identifying the FSH and LH behaviors throughout the follicular phase for us to consider, let it be obese, let it be non-obese, to alter our so-called individual approach? Prof. Fatemi.
I think it comes back to the E2 per follicle. It's very simple. I mean, if you have reached a certain systemic FSH level and you expect your follicles are growing, but your E2 per follicle is very low, that's a patient who would most probably benefit from co-administration of LH or ACG activity. So most probably these are the patients who would benefit. But measuring just the LH itself, I don't think that's a correct way, because when do you measure? Do you measure after you have given the antagonist? Because the antagonist obviously for 24 hours is blocking your LH production. Do you measure day 2 or day 3? But that's not reflective of what you are doing. On the other side, specifically obese patients, if the BMI is more than 35, sometimes the antagonist doesn't work. So they will ovulate because it gets diluted in the fatty tissue. So there's a publication, GCM, looking into that. So for example, we have stopped giving those patients the antagonists. We don't give antagonists. So what we do, we give them progesterone, reduce the progesterone primed cycles in order to prevent them ovulating. The only problem is that what kind of progesterone do you use? If it's a progesterone, natural micronized progesterone, still that suppresses your LH, so you cannot measure your LH. But you could also use dihydrogesterone. You see dufastone, and the dihydrogesterone, you cannot measure that in the blood, so the progesterone is not measured, and the impact on LH would be limited. On the other side, there are studies on cardiac malformation of dihydrogesterone, so also we have to be cautious. You see, everywhere you go, there is some issue.
Well, it's a lot of things, so we can individualize the patients. So, look, I think we're running out of time, but I really would like to thank everyone, particularly the Professor Human Fatemi, who's really kind enough to actually stay this long to share us his knowledge. Very, very esteemed guest that we have today. So, and also the panelists that we have, Dr. Chakra, Dr. Binawan, Dr. Ari, Dr. Belioni. So I would like to extend a round of applause for everyone this afternoon. For that, I'm giving this back to the MC. Thank you.
Thank you.
Thank you.